Hello, my friends. I hope you're doing well. I'd like to ask for your thoughts on this case that I show here to you, that I'm showing here to you. What do you think are the possible treatment planning for patients like this? My question now is related to a post I made on Instagram a few days ago, and it generated lots of comments and also some passionate discussions. People want to do what they think it's the best approach, but take a look. In orthodontics, it's not about what we think. It's about the right treatment planning for each specific case. And it comes with the right diagnosis. From that point, we can establish the best treatment planning for that patient. And my question now is it the best approach for a patient like this to treat with expansion, distalization, extraction of premolars, extraction of canines? And let's take a look what happened here. What we see now is most probably because of the loss of the premature loss of a deciduous molar, and in this case of a first deciduous molar in a later phase of the development of the occlusion. And why do we know that? How do we know that? We know that because if it happened in an early phase of the development of the occlusion, in the transitional period, it would have blocked the second premolar instead of the canine. Why? Because the second premolar is in a higher position and is palatally displaced in an early phase of the development of the occlusion. So this is probably what took place here. For posterior teeth migrated mesially, and it's not about maxillary constriction. No, it's not about maxillary constriction, and not also about mandibular constriction. We don't have it here. And we don't have a genetic arch length tooth size discrepancy. It's not about it. What happened here is most likely the loss of a premature loss of the deciduous molar. And it's important because it can generate the right treatment plan because we know what happened. Let's move on. So in this case, if we think about expansion, because people think that by expanding, we can solve almost all problems in orthodontics, but expansion comes with a very precise set of indications. Let's say, we don't have it here. We don't have the maxillary constriction. What we have, posterior teeth migrated mesially and it blocked the canine. So let's move on. What happens when I expand the upper arch? Let's say I'm doing that by using a Hyrax, like in this example here. And by using the Hyrax, what am I generating in such cases? Well, expansion is going to open a suture between maxillary left and right sides, and this is going to generate as well the opening of the diastema if we have a good expansion. And the diastema is going to be closed physiologically by the action of the transeptal fibers. So the transeptal fibers are pulling them together again, okay? So this is going to generate more space distal to the central incisors, and also the lateral incisors, they tend to migrate mesially, also because of the action of the transeptal fibers. And yes, this way we are going to generate space for the canine. How much space? It is important. But let's go to another problem here. What we need now is to accommodate the lower arch to the expansion of the upper arch, because you generated that. You thought that would be the best option, and then you expanded the upper arch. And now you need to expand the lower as well. But remember, in this case, it's a class 1 patient. Facial type is a class 1 patient, and I won't bring the mandible forward. I'm not generating a mandibular displacement, advancement of the mandible, I mean. So in this case, I'm not accommodating the transverse discrepancy of the upper arch in an anterior position, in a posterior position of the upper arch in relation to the lower. And I'm not in need, in this case, to expand before advancement of the mandible. So now I need to accommodate the transverse discrepancy that I generated by myself, because I thought that it would be a good option to open the transverse discrepancy to widen the upper arch. What happens now? When we don't have a problem, a transverse problem in the lower arch, lower teeth are not lingually flared this way, inclined this way, what happens? Now I need to expand the alveolar expansion for sure, and I need to expand the lower arch. Is it a good option? Well, I don't think so, because you don't have a transverse discrepancy in the lower arch that is common, for example, when you have a maxillary constriction and the lower arch is compensating the maxillary constriction by constricting itself. It's not the case here. So now I need to do this. I need to expand the lower arch, and this expansion may end up generating two problems. One, you can see here, is the fenestration of the buccal cortical plate. Oh, wow, very bad, huh? I didn't think about it. Yes, you should. You should, because this is a very bad thing to do. And there is another problem. Let's say you generated inclination of upper teeth. What happens? We are going to end up with a buccal inclination of upper posterior teeth, which is very bad for the smile. The perceived smile in cases like this is unattractive. We don't want that to happen, do we? Of course not. Let's take a look at this patient. Let me go to another place. Look, guys, we don't have, in this case here, wide buccal corridors, meaning I don't want to invade buccal corridors, and I have a class 1 profile. So let's go back. What do you want to do in a case like this? Is not expansion, but let's think about, let's say you did that. Good expansion. How much? I don't know. Let's say 8 millimeters. Is it enough? Remember, you have the canine blocked in both sides, and the premolars are contacting the lateral, meaning I have 8 plus 8, 16 millimeters. Do you think it's possible for you to expand 16 millimeters without losing anchorage in posterior segment? And do you think it was indicated for this case, this type of expansion? Of course not. First, possible it is, but it's not advisable. Another thing, even when we create the space, part of the space is lost by mesial displacement of posterior teeth. But let's say you did that well and it didn't happen. Okay, you have another problem now. What is the other problem that we have? Let's think about the case that we have now. You generated the space. You opened here 16 millimeters. You were a hero. You did that well, but still have a class 2. You didn't generate space here by distalizing molar, distalizing premolar. You generated space by expansion. In my mind, wrongly indicated. I would never do that in a case like this. And you see why. You understand why. You probably understand why now. Take a look, guys. This is a class 1 patient. If we consider the premolar as the canine, it is a class 1, and the premolar will act as a canine, and we can give a little bit of a torque in this area as well if you want to generate more volume here, if you want, if it is indicated. I mean, we can do everything. Another thing, your occlusion, it doesn't know that there is a premolar or canine there. If you generate a good occlusion with the lateral function with a group function, do you think it's going really to play this bad role in the development of the occlusion with time? And well, I really think science needs that type of proof, so we can avoid doing that, but we don't have it. We don't have it. So class 1, second premolar destroyed. Here we have also, because of the premature loss of posterior teeth, also in the mandibular arch, the migration of posterior teeth. Why not extract this premolar? Why not extract this one? In this case, the first premolar, the other side, the second premolar. I see no point here. Well, if you wanted to correct this with a good correction of the position of the molar, because if you expand, you still need to correct the class 1. You need to distalize upper teeth to correct the class 1. If you think extraction is not a good option, it's not an option at all in your cases, think about what you need to do. If you have space, in this case you have space, like extraction of the third molars would generate space and you can distalize. Good luck after that distalizing the premolar without contacting the root of the premolar against the root of the canine. Good luck with that. And also, good luck with bringing it down, freeing the root of the premolar of contacting the root of the lateral contacting the crown of the canine. Very difficult, huh? Biomechanically speaking, you are now in a very challenging situation. So take care. Think about it. Maybe you think when you do that, you're protecting your patient because maybe you're collapsing the tongue distally and then generating breathing issues. Well, is it really going to happen? Come on, take a look at this. This is a class 1 case if you consider the canine absent of the equation. And now you're just extracting canine and also extracting the premolar. What happens? The tongue is there. What happens to the tongue? Canine out, premolar out, second premolar out, mesializing lower. And let's say you kept that. Canine out and the incisors are stable. What happens to the tongue? And there was people asking me, but if you do that, come on, you're not generating expansion because you can expand. If you distalize, you're not generating more space. But if you think you can generate more space by opening this, by proclining upper anterior teeth, good luck with that as well. You are going to have severe fenestrations and you're not generating the solution for the case. You can have a better position for the tongue just by applying the torque. The incisors may even increase the inclination if you apply the correct torque. So I really don't understand what people think. We as orthodontists, we choose the mechanics. What chooses the mechanics here is the occlusion, is the diagnosis, not you, not me. After the correct diagnosis, yes, you can choose between certain types of mechanics for that specific treatment, but not from the beginning trying to impose to the problem that you see the mechanics that you choose. I want to expand. I don't want to distalize. I want to do this and that, because those treatments, they have right indications, okay? So think about it.